I'm going to share my screen. I'm going to attempt to share my screen. Let's see if I can do this. Are you guys seeing the presentation view? Great. All right. And you're probably seeing, do you see all your faces and the controls and everything too, or just the presentation?
We see the faces too.
Let me see what I can do. All right. Well, we're just going to have to flow. It's just going to have to flow. All right. Let's start with introductions. I don't even have my list in front of me. So let me see if I can attempt to do this by memory. We'll start with Cascade. Do we have anyone from Cascade on the line? Catholic Charities?
I'm Dusty. I'm with Catholic Charities.
Good morning, Dusty. Children's Home Society?
Good morning, Samantha with Children's Home Society.
Columbia Basin Family Medicine? Columbia Basin Health Associates? Confluence?
Tess is on the line.
Good morning. Family Health Centers?
On Thompson.
Morning. Grant Integrated?
I'm here. Mike's here.
Morning, Mike.
How are you?
Moses, I'm well. Thanks for asking. You must have missed my whining. Mid-Valley?
Good morning. This is Diana, and it looks like I have Becky and Afton with me today.
Austin. Great. Thanks for joining us. Samaritan?
Good morning, Shania Clint from Samaritan.
Morning, Shania. Cooley Medical?
Hi, this is Shoshana Palmentier, Cooley Medical Center.
Okay. The Center? Let's see. Cascade Medical. Has anyone joined us? Columbia Basin Family Medicine? Columbia Basin Health Associates? Just so you know, I'm frantically looking to see which organization I've actually missed. Clinical organization.
Columbia Valley.
Yes, Columbia.
PH. Thanks.
Hi, Mary Louise. Sorry about that. And I'm missing one more.
And Moses Lake Community Health Center. And this is Stephanie Dowland.
Good morning, Stephanie. I just must have skipped over you on my list. I had you down. How about Action Health Partners?
Deb's here.
Good morning, Deb.
Good morning.
Mayor Group?
Hi, Kate here with the Mayor Group.
Good morning. Coordinated Care? CHPW?
Good morning, Wendy. This is Kristen Stagner.
Good morning, Kristen. And Melina?
Good morning. This is Vicki Evans.
And this is Misty
Good morning,
Quinn.
Vic.
And Jackie Weber.
Cam Tepling-Zwagel.
Donnie Guerrero.
Good morning, Melina team. How about CSI and CCMI?
Morning, Christina's here.
Roger Cheffany is here as well.
And Connie Davis is here also.
Wendy, you're muted.
Thank you, Teresa.
And I don't think you
When you
called
have
out
two-
OBHC.
Yes, that's who I'm missing. OBHC. Thank you, Teresa.
I am here. Hi, everybody.
Good morning. So because of my mishap that started actually on Friday, if you send me a private message, no, it'll be to everyone because I have to share screen. I just sent it. They are uploaded to the dog vault, so you can access them from there. But what I did was, because I'm still struggling, I went ahead and added the agenda to today's meeting. It's probably going to be a short meeting. I had planned to do the improvement data and the VBP, and I just was not able to get through it this month just because we have a big telehealth proposal, and I thought I could do both, and I was just not able to pull it together to my satisfaction to be able to share with you. So if you logged on just to hear that, I apologize. We'll pull it together and hopefully have it ready for next month. So we just have a few updates, and then we'll have a presentation from Children's Home Society, a presentation from Molina, and then we should be over. So that's the agenda. And then let me show you the minutes. If you're not having, basically it shows the, let's move this out of the way because I don't know how to minimize it. I'll let you review those. And once we review those, if I can get a motion to approve both the agenda and the minutes. Anyone want to make a motion?
I move to approve.
Thanks, Tessa. Do I have a second?
I'll second.
Thanks, Lisa. And I can't see any of you, so if you would please unmute and just say if you approve the minutes. I just need to hear people, I think.
This is Afton. I approve.
Approve.
Mary Louise, I approve.
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 Thank you. Anyone opposed? Okay, minutes and agenda are approved. See how to do those. Announcements and updates. Does anyone have any updates that they would like to give regarding your organization? Mid-Valley, I'm sorry to put you on the spot, but if I recall correctly, Becky, did you send an email saying something about the AIM Center grant? Were you guys applying for that?
No, we're in cohort 2 that just launched last week.
You're in cohort 2. Awesome. Is anyone else applied and is going through that from our region? Any other organization? Okay. Anyone planning to apply to the next one? Okay. Excellent. Okay, there's no other announcements from you guys. I will let you know, I just received an email, I'll send it out, that the Rural Facilities Capital Grants Partnership Fund, that's the Primera Empire Health Fund that funds rural health facilities. That grant application opened today. It's for $25,000 to a $100,000 range, and it's for capital equipment and for whatever you may have. So I put the web address, the empirehealthfoundation.org web address there at the bottom. So if you're interested in that, just know that grant opened today. So if you're still in need, I'm thinking of telehealth or other capital equipment, check out that grant. We did have a few in our region who were awardees on the last grant. I may say this round, I'm not sure if it was North Valley or Three Rivers received it last time, and then another hospital district, and I'm not sure who, which facility that was. So that's an opportunity you can take advantage of. Just a quick reminder that reports are due on Wednesday, March 3rd, always the first Wednesday of the month. If you can have them in by the close of business, and if you can get them uploaded to the portal, we appreciate that because we've been doing, starting to do monthly reports. So kind of writing up some things from a practice facilitator's point of view and questions. And we are looking at that. And we also use some of that information and it helps guide our work for those who are participating in the population health line of digging deeper. So if you'll have those in by Wednesday, close of business, that would be great. And the other new announcement, I'm sorry for those Grant County facilities that I have not been able to contact sooner. Mariah is going to take over all the practice facilitation for North Central Washington. So I've been covering Grant County. So for those organizations in Grant County, Mariah will be your new practice facilitator, and I will send that individual email out to everyone and do that formal introduction and make that connection. I'll still be on as the WPCC manager, but the actual practice facilitation report reviews and meetings to go over that kind of stuff, Mariah will take over.
Wendy,
Any
I want
questions?
a picture of me for your slide up there by the reports.
You know, I snuck in, Lisa snuck in and got it from you.
Obviously having a better hair day.
Oh, any other questions, comments? Okay, I am going to stop my screen sharing and I'm going to ask, I'm going to turn it over to Children's Home Society and let you do your screen sharing and share your presentation.
Okay, can you guys see that?
We can.
Okay, excellent. So yeah, I'm Samantha and I'm with Children's Home Society. I'm the whole person care coordinator for our agency. We are a behavioral health service and we serve children and families. Some of those programs include our therapeutic foster care. We have a child and family therapy team. We also offer a WISE, which is a wraparound service. It's a more intensive service for those youth that are higher needs and are involved in multiple systems. We also provide like parent education. So we do parenting classes like the Incredible Years parent training, Triple P. We're also in the school system. So we do the Readiness to Learn program, and we're also part of the truancy intervention program. And we recently just started a new group. It's a peer group for LGBTQ called Triple Point. So the whole person care coordinator, my role as just definitely developed over the last few years. It started with simple referrals. It was PCP referrals, transportation referrals, to sleep studies. And really over the last few years, it's moved to a more hands-on focus through the change plan. And now we are focusing on tracking high BMI scores and depression screening and follow-up. It's been collaborative work with the child and family therapist supervisor, developing the change plan, and also collaborative work with our child and family therapist team. They've been helpful in collecting all of our data. So for high BMI, our agency chose high BMI scores as a focus. We don't have the capabilities of collecting A1C like some of the other agencies, so we chose to do the BMI. As you can see from the Obesity Action Coalition, childhood obesity affects more than 18% of children, making it the most common chronic disease of childhood. And so how we were doing this pre-COVID days, we were weighing and measuring all the youth in the office to collect our BMI scores. Now we're all virtual, we're all working from home. So we're just simply asking the parent or the youth their height and weight to collect this data. may not be as accurate as we'd like, but that's the reality of COVID at this point. And we're entering this data into our EHR system, and it is calculating a number and percentage. So if a client that scores above the 85th percentile at intake are then referred to the whole person care coordinator, myself, we are tracking each of these clients in an Excel spreadsheet, putting down the client's name, their BMI score. They are sent a letter and resources, and then we are doing a follow-up call for regards to outcome. They're sent a letter. It includes like their PCP information, so that way they can contact their primary care to maybe connect with nutrition services. And then 3 months later, I'm contacting family to ask if there's any questions regarding the resources that are sent, and being able to answer any questions that the families may have or needing assistance with connecting to their primary care provider. This is some examples of the resources we've been utilizing, just things like from myplate.gov. So teaching families to be active families, choosing smart snacks, what childhood obesity is, the causes, the effects that it has. And for our other measurement, we are doing the depression screening and follow-up. So we're utilizing the PHQ-9 to assess clients 12 years and older for depression. This is a new measurement for us. We had previously focused on trauma, so this has been a new process for us starting this new year. Therapists, so they're assessing initially at intake, and then monthly once the client is referred and assigned to a therapist. The client scores 15 and above at intake. The therapists that are administering the Columbia screener, and then a safety plan is created upon the clinical judgment. Typically, the therapist will create a safety plan if they're scoring at that high of a number. Here's an example of just the Columbia depression screener. And so it gives us a risk level from low to high, and then that allows the therapist to know what kind of services that they might need to be having the client access, whether it's a call to crisis or creating that safety plan. And so through the population health, it's really been helpful for us to kind of see where we need to make improvements and changes. And so we did the fishbone diagram for our depression screening and follow-up. We sent this fishbone diagram out to all of our therapists to get feedback from them to see what they thought was the cause for the depression screening not happening. We did it in the 4 different areas. Provider, people were thinking that it was staffing changes, maybe high caseloads, forgetting to screen regularly as it is a new assessment. External factors would be like the lack of working resources, some families maybe not having internet or internet that's not working, patients not showing to appointments, maybe refusal to complete the assessment, and then the system. So maybe not having a tracking system or a workflow to screen regularly. And then we took all of that information that we were given and listed it A to M, and we used the nominal group technique, asked all of our therapists to give us some anonymous feedback regarding what they thought was the most influential for this screening to not occur. What we found out was our top 3 findings were that the clinicians were forgetting to screen regularly. Clients sometimes were no showing appointments. And then the third one was that we didn't really have a tracking system to help ensure that the screening was occurring on a regular basis. So when we found out that information, we took that and we created a workflow for all of our assessments. This included when to screen and where to record the results. Again, as I said, our PHQ-9 is something new for them, and they do many other assessments as well. So I think they just needed something a little bit more clear for them to be able to get all of the assessments done on a monthly basis. I created an Excel tracking sheet for each of the therapists to track this monthly. It included the youth's age, their diagnosis, their score, and if there was a follow-up plan needed. And then also recently we had set up a reminder in our EHR system at the beginning of each month for all those clients 12 years and older. That way the therapist has a little reminder pop up for them that it's due. Here's just an example of the workflow that we put together for all of our assessments, you know, when they're doing the assessment, where they can find it, where they can save it, and whether we're reporting on that assessment or not. This is just an example of that therapist tracking sheet, a little snippet of what I created. As you can see, like this example, all of these kids with ages 12 years and older, their diagnoses and no score over 15. So there was no follow-up plan needed. And next steps for us. So continuing to collect this data to see improvements. Like I said, doing the PHQ-9 for us has been new. It just started in December. So we're just really starting to get into the routine of screening and collecting our numbers to hopefully see those depression numbers decrease over time. And we're surveying our therapists to get feedback on how they feel about administering the assessments, how their clients feel about the assessments, and then hopefully taking some action once we do get those survey findings back. And I think that is it for us. Anybody have any questions?
Thanks, Samantha.
This is Tom from Family Health Centers. When you do the PHQ-9, are you doing it every visit or once a visit? Like, what does it look like with doing that?
Yeah, so the PHQ-9 gets done initially when we have a new client come in during their intake assessment. And then from that point on, the youth is administered it once a month. So generally our kiddos are seen on a weekly basis. And so they're being assessed on a monthly basis. And really that's left up to the clinician to when they want to do that within that month. We don't have like a set date that everyone is administering it. Does that answer your question?
Yes, thank you. And also, are you doing it on paper? Do you collect it orally? What does that look like?
Oh, yes. So we're all working from home still. So we're doing it electronically. We have it already built into our ICANN notes, our EHR system. And as far as I know, it's being done orally. And then a lot of times you can, you know, we're using Zoom as well. So we're screen sharing. And so you can actually share the screen and they can read it at the same time to be able to record the client's answers.
Thank you.
Yeah, you're welcome.
Any other questions? Samantha, I'm curious, as you brought all your staff through this process, were there any surprises that you learned?
So we did recently do that survey, our plan of action. We had just finished that up and not really surprised, but good to get the feedback on. I think a lot of the therapists, it's a mixed feeling about administering another assessment. I think most of them see the benefits for our clients. A few of the therapists just feel a little overwhelmed because the timing at the same time they're doing a CBT training, and because of that training they're administering other assessments every 2 weeks for that certification for that training. And so I think with that and the timing combined, they've felt a little bit overwhelmed with the changes, but they have felt that adding in those workflows has been helpful for them, and just, you know, trying to make sure that we're getting the reporting. We are screening. It's that process of learning for them to report back to me so that way I can actually collect those numbers.
Great. Anyone else? Curious, does anyone else want to share their experience with the PHQ-9? I know several of you have rolled that out recently. Have you had similar experiences?
Wendy, this is Lisa from OBHC. I can't say that we've had similar experiences since we just implemented it last week, but we did have in the first week a successful outcome as far as we've implemented the use of the PHQ-9 in our substance use disorder program so that folks coming in for drug and alcohol assessment get the PHQ-9 administered. And we had a client that came in and we were actually able to, throughout the course of the conversation and after the PHQ-9 was administered, it was determined that that client actually needed to be seen right away by somebody on our crisis response team. And so that probably wouldn't have necessarily been the outcome had we not used the PHQ-9, as the client was a little bit hesitant to even really broach that topic, and I don't believe would have ever brought it up on their own. And so it was really nice to be able to link that individual up with mental health services right away, and really be able to address those things as well, and not just the drug and alcohol issues that they initially came in for.
I think you're muted, Wendy.
As I am muted and talking. For those of you, have others looked at rolling out PHQ-9 in other settings, not just your typical, I'm going to screen on well child visits, but maybe like during your vaccine clinics, to capture potentially those individuals who may not seek care otherwise, or seek care for their mental health? Seems like there was a presentation from Southwest or Southeast Washington, I'm not sure now, where they were using it during one of their drive-through COVID vaccine clinics, and had a plan in place to address issues that needed to be addressed immediately, or to call patients and reach out after the fact, which I thought was a pretty novel idea.
This is Tessa from Confluence. We've been doing this initiative for a couple of years. It's been a huge rollout at Confluence Health. We give the PHQ-2 to every patient coming into primary care, which is about, for us, about 24,000 visits a month. And then we also give the suicide question. So we kind of call it the PHQ-3. And then if they're positive on that, they would get the full PHQ-9 and the Columbia if they're positive on the suicide. We're at about a 56% rate. We have a goal that we want to get to 60% this year of all of primary care. We have a pretty good report that we can drill down and see by provider, so by department, and then also by provider, how many patients they saw that month, how many patients of theirs was given the PHQ, 2 at least. So it's a pretty good report, but this has been ongoing for us for about 2 years. It's a really, especially in a larger organization, it's a really hard initiative, but important one.
Right. Do you find some areas you have better response because you guys are spread out across the entire region? There's a better response in some areas than others?
I mean, we definitely have champion departments. Women's health, for example, is always in like 95% every month. OMAC, up there in their primary care, that's where we're doing our AIMS grant, so we really have focused in. They're about 85% of every patient coming in, and we do every patient, every visit in primary care. So again, it's about 24,000 PHQs that are supposed to be given out to try to catch this in this important measure.
That's great. Thanks for sharing. Any other questions for Samantha? Connie said in the chat, I'm not sure if you saw, a great use of the QI tools. And Tina said, love to see how you use the fishbone diagram to build theory. Also how you engage staff in developing solutions. Yeah, excellent work. Thank you for sharing. And with that, if there's no other questions, I'm going to go ahead and turn it over to Vicki from Molina and her team. I think, Vicki, are you going to share your screen?
I'm going to try, yes.
Okay.
All right. I haven't done it on Zoom before. It seems like it's always Teams. So let me make sure that yep, it looks like it's pulling up. Can you see that?
Not yet. Or is it just me?
There is a share button that you have to hit, Vicki. That's something I've had to learn the hard way too.
I hit it originally and it has it outlined and that it's showing on my screen, but it's not. Oh, I see. It came up again. Share. Okay. Is that better?
Yes.
That's better. We can see it.
Can you see it? Okay, but now it sort of disappeared. So let me practice for a minute with all of you. Now,
we can actually see your screen.
You can see my screen with the presentation, right?
Correct.
Okay, not my other screen. Okay, I want to make sure I have the right screen. But how will I advance? Because I no longer, I lost the rest of it. So I don't see how I would advance the slide.
Can you use your arrow keys on your keyboard?
No, they don't work. Let me, yeah, I don't even have, I completely lost where everybody.
If you click on it, Vicki, if you just click on the presentation, will it move forward?
Yes, but how do I get to go back now?
Don't ask me that. I got you going forward.
Okay, I got back. So let's see. So everyone bear with me. Obviously, I'm not here to present on anything that's related to IT. And if you need technical assistance, maybe don't call me. But that being said, thanks everyone for giving us some time today. We have quite a few of us, as you can see, that will be presenting. And I'm looking to the left because that's where my other screen is. I'm not trying to be rude. And so anyway, we're the Molina team, and we have a number of folks that are located in the region, and then some of us that are not, but work closely with the North Central region. And so we have a whole group of us coming together that are all the different contacts that various folks in this call interface on a routine basis. So we thought what would be helpful would be to give you a kind of a big picture overview of all the activities that we were involved in during 2020 that we felt were really key. We think, lots of times what the MCOs are doing may be kind of in the backdrop, because we're seen as an insurance company. And we do so many other activities as it relates to looking out for our members and the communities. We just thought it'd be helpful to showcase some of these efforts that many of our staff put forward in order to have come to fruition. So with that, I will move to the next slide. So anyway, my name is Vicki Evans. I think everybody here knows me, but I'm the Director of Behavioral Health and Behavioral Health Integration for Molina in Washington State. So some of the things we did out the gate is we wanted to connect members to needed care and services. We know that COVID obviously came on pretty quickly as it related to us realizing how serious it was, and as the pandemic advanced, the impact on all of us, but obviously those we serve, and particularly the Medicaid population, who oftentimes have so many disparities, as we know, as it relates to access to care, getting care, and then just the challenges in making sure that we continue to take care of them to the best of our ability. So the first thing we did is we really got involved with encouraging and promoting telehealth by Molina providers. We also have a 24/7 virtual urgent care when Molina providers are not available. And this is available for any of our members, although we do direct them to their primary care and other providers during standard hours. But after hours, this is available, and we have agreements with our providers so that any information that comes through virtual urgent care is passed back to the primary care provider, so that we're not operating in a solo position and or doing something that might be contraindicated. We also reached out to all members impacted by COVID. We track the numbers daily, see how many of our members we're aware of that were positive. We outreach to them. And we also did the same with wildfires. So we had a whole team of folks that were involved in identifying needs for those impacted by wildfires. And in fact, the team over in Eastern Washington, Misty and her team, were awarded with a Molina Corporate Award, which was very rare. It's one of the only in the whole country after many, many different work efforts were submitted for both identifying needs and for all the, boots on the ground, basically to take care of our members who are impacted by fires, on top of what was already going on with COVID and that. So we also provided pandemic care kits. We provided food to people at home that had been, that were Medicaid and Medicare members that had been diagnosed or were living with someone with COVID, to try to keep them at home, socially isolated and also taken care of. We waived all COVID-19 out-of-pocket expenses for members for all of our different lines of business here. The coronavirus chat box was set up so that we had a tool so that our members could go to our website, get information and understand different issues around risk factors and what they could do next. We provided smartphones to folks that needed it, as well as minutes that were allocated by the state in order to make sure that people had a way to get a hold of providers and to get care as needed. We know that's not perfect, and there's broadband and other kinds of issues that impact service, but our goal was to make this as easily accessible as possible. We also offered 90-day prescription refills and encouraged use of mail-in pharmacy when needed, so that individuals could make sure that they had the medications they need, particularly for chronic health conditions. We promoted food access through Amazon, and then free delivery of other essential services via Prime benefit that we offer to our members. In terms of supporting providers, there was a lot of urgent needs. We know there are a lot of financial needs as we were going through the pandemic, and as it was becoming more apparent, the serious impact on both access to physical as well as behavioral health care. We contributed 15 million in direct payments to primary care and substance use disorder providers, primarily residential treatment and opiate use disorder for the SUD. And we accelerated claims and incentive payments. We set up a daily and daily reviewed any claims that were not turning around pretty much immediately to make sure that money, when claims came through, they were paid. We typically do that, but we really every single day making sure there weren't any obstacles to getting provider payments. Offered 8 million advance payments to some of the behavioral health organizations. Can you see that my internet connection is unstable? No, maybe it is.
Everything looks fine on our end.
It looks fine, Vicki. It's just your voice cuts out periodically, but we get the gist of it. It's not.
Okay, good. Thank you. We gave 1 million in PPE, food, and financial support to enable telehealth access, and had significant deployment through our provider partners. We really appreciate everybody coming together and working with us to help us get information regarding our members and to figure out how to best serve them. We routinely updated our, member and provider resource pages and that, but we really did a lot of outreach. I think our sense was that our members really needed us to be speaking directly with them and making sure they were getting the information that they needed to be able to take care of themselves during this time and to have accurate information. We worked with providers to make sure that that was also happening, that there was continuing ongoing care for chronic conditions. If there were issues getting a hold of members in any regard, we certainly helped with that and helped members get what they needed related to routine care, as well as the chronic condition care and immunizations. There were many changes to frontline care providers, including relaxing prior authorization requirements so that there weren't any obstacles to getting people immediately into care, and extending our current treatment authorizations through December. We also support expedited care transitions through expanded staff coverage so that we could really make sure that members were getting their needs addressed quickly. In terms of supporting communities, we donated 200,000 to over 100 food banks, and that included every county in the state of Washington, so all 39 counties. We donated thousands of PPE items via COVID community response, again, during frontline community partners. We supported Molina employees who are licensed providers that were able to get time off and go out and provide additional care in the communities to those in need. And then we had ongoing donations, personal hygiene items, food, clothing, and other kinds of support to tribal and community partners across the state. We all know that telehealth became of importance and significance during this time, and that we had to deploy pretty quickly, both training for providers and as well as members on how to use this. And so we were very involved with outreaching to all of our behavioral health providers and many of our physical health providers to see what we could do for support. And we're also able to provide some trainings, particularly those that deliver autism services, which we initiated with the Healthcare Authority and other MCOs, and others participated in to help get training to those that serve individuals. I think for behavioral health and for those serving autism, serving individuals over a telehealth platform is really unusual. So lots of effort that needed to go into that to make that successful. That came from all sorts of people in the state. So this is more about Molina joining than anything else. As you can look here on the left, you see the 2019 telehealth trends. You can see green is telehealth visits, of which there's very, very few. It looks pretty flatline, both for physical health and for behavioral health. And then in-person visits were most all of the visits. And then when we look at 2020, we see obviously starting in March and then moving through the end of 2020, a sizable increase in telehealth visits, particularly in April, and then dropping off some, but then rising again a little bit towards the end of the year. And then we can see here the in-person visits and how significantly they dropped off, and then the return over time to that, although we still had many more telehealth visits than we did obviously pre-pandemic. So we're able to break out our data and look at what kinds of telehealth is being provided in terms of the most common diagnoses, which we thought would be helpful just in terms of understanding our members' needs. And we're able to go through and look at the top 10 behavioral health specialty, as well as the top 10 physical health provider specialty. And so we can see both provider types, as well as down below see top diagnoses. So as you look below on the left, we can see the behavioral health top diagnoses were PTSD, generalized anxiety disorder, major depressive disorder, opioid dependence, alcohol dependence, and other stimulant dependence, principally methamphetamine as we look at data these days. And then for physical health, we see again that opiate dependence is represented at the top, is related to the top physical health diagnosis for which folks were looking for support through telehealth. And then we see contact exposure, other viral communicable diseases, encounter screening for other viral diseases, anxiety disorder, mixed receptive expressive language disorder, and autistic disorder. So I think of note here is really of the physical health diagnosis, how many have to do with a behavioral health condition and or something else that we commonly think of as having like autism, where we know that there's significant behavioral health factors for many. So with that, I'm going to pass off to Misty. Misty, you want to introduce yourself and then take it from there?
Yes, hi, I'm Misty Queen. I'm the Director of Healthcare Services for the Eastern Washington teams. And so here we're talking about our COVID-19 vaccine efforts, and we did quite a bit around this, including with our members, our providers, and in the community. So for members, we are doing text automated calls to our members to either let them know they're eligible or that they're due for their second vaccine. Also vaccine education in all of our inserts for our member mailings. We also have an internal dashboard that's tracking vaccination rates for our members, and then FAQs are being posted to our websites. For providers, we've worked on our billing to make sure that they have billing configured for the vaccine, the COVID-19 vaccine specifically. Partnered with our skilled nursing facilities and long-term care facilities for a vaccine plan for our members, and also made sure our provider website is up to date with the latest COVID-19 vaccine information. And in the community, like Vicki has already talked about, we've done numerous volunteer efforts with our staff to get those vaccines out and into our members as well as just the community members. We've supported vaccine education outreach via social media, mobilized efforts to leverage Molina Mobile Unit to assist in vaccine administration as well, and exploring opportunities to leverage our Molina Cares Foundation to support vaccine outreach for the high disparity population. So we're really trying to have an active part in getting that vaccine out. Jackie, I believe you're next.
Hello, I'm Jackie Weber, and I'm one of the supervisors for the Eastern Washington Case Management Team under Misty. So we have a variety of case management programs that are voluntary for the members to participate. They involve improved health outcomes and assisting members with managing their conditions and providing them with the needed resources and referrals. So that's our local team there with the Molina van and some of our kids that really help when there's a volunteer event that Donnie gets us when we can do things outside of the pandemic. It's really great. We've had a lot of family volunteers as well as employees. So we really pride ourselves in pitching in and everybody helping. So Vicki did mention quite a bit about what we did for 2020 with the COVID and fire response in North Central Washington. Specific to our region, we spent a lot of times calling the members that were up in the Brewster area and Bridgeport area, talking to them, making sure that they had everything they needed for medications, durable medical equipment, and making sure that they knew where the Red Cross shelter was, where to get food, and just managing that. The COVID response calls, like Vicki said, all Molina members are being outreach to, and Confluence Health reached out because of the large volume of positive members that they were having and asked, and we've agreed to partnership with them so that our case management team made all the calls for their COVID positive members. It was a really neat experience to be able to work with the local individuals and answer questions and for them to know that we're right here with them and able to help them. So we did offer the 2-week meal kits to our members, but fortunately for us, we had a lot of resources already in our valley. So a lot of that wasn't used here in North Central Washington, but we enjoyed it. Now on to Donnie.
Donnie, we can't hear you. I'm not sure if you're still on mute or not.
Washington team, so that includes Spokane, Greater Columbia, and a little bit of the North Sound. So a little bit has already been covered on what we've gone ahead and done throughout the pandemic in 2020. But I'd like to go ahead and highlight some of that here and how it actually went ahead and impacted the North Central Washington communities. So at the beginning of the pandemic, in the middle of the year, Molina went ahead and distributed over $100,000 in funds to local food pantries and food banks. I went ahead and specifically focused on our smaller communities that would traditionally go ahead and get a lot less funding, a lot less resources. And then we also, at the end of the year in 2020, we also provided an additional $100,000 for a total of $2,000. And those were evenly divided into 10 separate regions across the state. And so that second portion went to one of our food banks in Grant County. So that's just a little bit of the work that we were doing around food insecurities in North Central Washington. Next slide, please. In previous years, one of the regular things that we would go ahead and do is we would go ahead and partner with a lot of our community-based health centers and community partners, and we would go ahead and work during the wildfire season. We would hand out N95 masks. Obviously, this was not an option last year in 2020, as those were already being used by our essential frontline workers. So we went ahead and did, beyond the scope of what Jackie's team did in regards to case management, we were also providing using any of the funds that we would have normally used to purchase those masks and needed essentials to go ahead and purchase and donate essentials that were needed, especially to those communities that were highly impacted by their burning homes, their structures, their businesses. So we went ahead and provided basic needs essentials. And we were able to go ahead and partner with a lot of our community-based organizations, reducing a lot of the extra burden and stress that were already happening to our clinics and health centers. And we were partnering as necessary all across North Central Washington. Some of that included providing COVID-19 kits, both for adults and children. And some of it was specifically PPE. Other things also included items to help reduce anxiety and stress for kiddos, for adults. Next slide, please. Thank you. One of the things that we also went ahead and did towards the end of the year was we found that we also need to provide additional incentives to all community members to go ahead and encourage them to go ahead and stay connected to their doctors, but more importantly, also take their flu vaccination seriously. In 2020 is more important than ever. So we went ahead and partnered with a few local community health centers and Walmart. We went ahead and provided funds to go ahead and provide flu vaccinations. And some of the funds we also went ahead and allocated. We went ahead and purchased care baskets. So included essential food items, and those were available to anybody that came in and got their flu shot. And also any of the communities that were needing, that were lacking food in their homes, we were also providing that on the spot. We partnered up with Walmart to do the same thing, but with them there, we went ahead and we're providing them with gift cards to go ahead and buy urgent things on their need to the closest Walmarts that they had there. Next slide, please.
I'm trying. For some reason, it doesn't want to. Okay, let me try something else.
Not a problem. Thank you, Vicki. So our work continues. It doesn't stop with just that there. So obviously, every year we have food insecurities throughout all of North Central Washington, all across the state. So we also went ahead and partnered with a few different school districts across Washington state. At the end of 2020, we went ahead and partnered with Quincy School District, and we were able to go ahead and have two different sites where we went ahead and distributed Molina Cares baskets. So this was food items around the holidays, specifically for Christmas. We went ahead and provided turkeys, hams, pies, all the fixings. Even though it was a time of hardship for a lot of community members and their families, we wanted to go ahead and still provide some kind of comfort in that hard time throughout the year. We were able to go ahead and also partner with CVCH, who does have a mobile unit that is currently out and working in the community. And we were able to go ahead and provide them with funds to go ahead and keep that work going. We know that it is essential, especially to those community members that do not have a working vehicle and maybe enough gas to come in and visit their doctors. And they could, that mobile unit is able to go ahead and connect with them out in their local communities. Next slide, please. So our work still continues. We have gone ahead this year. We know that this is, with a pandemic, it has gone ahead and seriously gone ahead and impacted a lot of our community members that would normally be unsheltered or homeless. But obviously, because of the pandemic, this went ahead and was able to affect our community members even more widely. So we went ahead and partnered with various different partners across all of North Central Washington. We were able to provide fundings, sleeping bags, just because the normal events that would happen around the normal point in time count were not happening this year. We wanted to make sure that we were there to help close any of those gaps that were necessary. I also got assistance from one of our community connectors in Grand County, and she's doing a lot of great work with our probation locations and for those individuals that are leaving jail and prison. And we were also providing them with PPE, hygiene products, things that are necessary at this time as they are reintegrating into the community during a COVID time. Next slide, and I will hand it over to Jackie Weber.
Are we making it, Vicky? Oh, we lost Vicky. All right. Well, I'll talk about what we have going on with this next slide. And so as the work continues, I currently participate in the Chelan Douglas counties in the quality mental health meetings that Confluence runs. And I'm going to take the lead on trying to expand that to Okanagan and Grant counties and see how we can collaborate with them. We're also, thank you, Donnie. Donnie's team continues to do the work and outreaching to people. So what we're doing here is at the start of the pandemic, Molina launched its Washington State Facebook page to better engage with our members and community partners around the state. So we started doing a series of simple videos to help people understand, and we partnered and featured with community health leaders around Washington just so that they could better understand the pandemic and what was available for them. So as we go forward, we continued that partnership with Cafe, and it looks like Dr. Bodell and community partners from Cafe are in the picture. Donnie is going to put in the chat box the Facebook link. And in 2020, Molina also was part of the Latinx Advisory Committee to the Chelan and Douglas Health District. And today this work continues with Cafe and their community service coalition. And the current work consists of making the most current information around COVID more widely available, accurate, and easy to understand, with a focus on reaching the Spanish-speaking community in North Central Washington. So at this time, the coalition is creating simplified flyers and posters and videos around, and let's see if I can butcher it, Si a la vacuna. So yes to the vaccine. I'm not sure if I said that right, Donnie, or not. So that video series is out and encouraging eligible community members to register for the vaccine. So I think our last slide is you, Pam.
And Whitney. And thank you for picking it up for me. Sorry, I lost internet connection.
Hello, everyone. I'm Pam Tupling-Zwagel. I am the contract manager for the North Central region. And what I'm going to talk about is primarily on the physical side. To help our providers, Molina sent out $10 million statewide to help our primary care support. For North Central Washington, that was to our hospital systems, our FQHCs, RHCs, who had Molina paneled members within Okanagan, Grant, Chelan, and Douglas counties. There was 13 primary providers that we sent these support payments to, which was just over $700,000, and that equated to 90% of our North Central Washington region members. So again, those were about 13 different primary groups. Whitney, do you want to do the substance abuse part?
I'm not sure she's here. Vicky, do you want to take that?
Do you want to just continue, Pam? I think you and Whitney had worked on this.
Sure. So for the substance abuse, there was also 10 million that was invested towards our SUD providers. That's all I know about it.
Okay, yeah, mostly we looked at the network and decided that those that did either residential treatment and or opiate use disorder, seemed to be the ones that were most in need. We know there was issues throughout the system, but that's where we ended up focusing on, just to ensure those services could be delivered. And I think in looking at the data that you saw earlier, it definitely was emerging that OUD, opiate use disorder, was of prime concern, both for physical health as well as for behavioral health. So I think that concludes our presentation. I really appreciate you jumping in, Jackie. Sorry about that, everyone. I lost connection. So I think we'll end there. If anyone has any questions, we can deal with that later, or however you'd like to, Wendy. And thanks to the team for presenting. I appreciate it. And I apologize for the technical glitches on my end.
No worries, Vicki. We are all having them, so I'm sure you and I are glitched today, but I'm sure others feel that pain other days. So any questions for the Molina team?
Great, thank you very much.
Vicki, I was waiting, but I actually have a question. On your trends data of the most, the common diagnosis for telehealth for both behavioral health and physical health, is that the North Central region, Washington State, all of Molina? What does that cover?
It's for Molina, and it's looking across the state. We do have some heat map information that I was able to look at. And it was interesting to note for the North Central region that there was definitely a tick up in use of telemedicine and telebehavioral health, but not nearly as significant as we saw other rural areas and other areas around the state. And I'm not sure what that would be attributed to. In fact, I would have presented the heat maps, but they were a little dated. I could only get data through the end of August because we changed systems and I wasn't able to pull it up in the same way to demonstrate it via some kind of PowerPoint slide. But at least through the end of August of 2020, we kind of have the heat maps based on number of telehealth contacts and then look by county across the whole state. And then we have it colored from a very light color for those that have low use up to red, which would be the highest utilization. And it looked like kind of was in the bottom two levels of what was about a 5-level coloring system. So the lowest two colors. So I don't know if there's other comments about that, but it seemed like in other rural areas, we had very high spikes and use, and it quickly rose to more of a red. So I don't know if that had to do maybe with broadband issues and just accessibility. And I also wondered, as I thought about that, if there was opportunity in the future, should anything, maybe during normal times, like, once the pandemic kind of continues to ease up and we move forward, or if something else, unfortunately, were to occur along the pandemic lines, whether there are resource issues for which there might be need for support in the North Central region. So anyway, I don't know if anyone has any thoughts about that, but I definitely would be interested in some conversation if we need to improve access. And if there's something we can do either through the broadband work at the UW with a whole committee of us that are working on that, and or through efforts that would be unique to the MCOs or Molina.
Does anyone have any comments on what she was asking of potentially why we could have been the lowest around the state? I would say broadband issues, or I would like to say it's broadband issues, but I think having seen some of the maps, there's broadband issues everywhere across the state, but maybe some of you can speak to why you may not have had the uptick in telehealth.
It wasn't
visits.
It just was in the lower. So again, where you have that sort of light color up to red, it was just in the lower arena of utilization. So there were other areas in the state that also had your lower utilization, but had changed color some. It looked like North Central was kind of flat, at least from what I could see and ascertain from it.
Thoughts, anyone?
This is Stephanie Dowland from Moses Lake Community Health Center, and my team works on the technical side in helping patients get connected. So if someone says, yes, I'm interested in telehealth, but I need you to walk me through it. And we just have a lot of people when we offer telehealth that just don't want it. They, it's on the medical side, it's like, well, is it really the same? I mean, if I have to pay for it, especially, they're like, is it the same? Can the doctor really do all the things without touching me and listening to my heart and lungs. I've been a little bit surprised because like I've tried to talk patients into like a medication follow-up for depression. And I'm like, yeah, this is perfect telehealth if you ask me. And so we've done a lot of like, well, if you don't feel like it's worth it, we can't charge you again, right? So I've done some educating about like, well, if you do it telehealth and you give it a try and you still have to end up coming in tomorrow, you don't get billed twice for that, and that kind of stuff. But I've heard a lot of patients that they're not sure it's as effective or it's as good as going in person. I've been shocked because I love it, to be honest, for myself. It's really nice, but I feel like I also do this all day over Zoom now.
Yes.
And so I think for a lot of our patients, it's different. They haven't transitioned as much of their life to remote as maybe some of the rest of us have.
Do you think there's something we could do, Stephanie, in terms of education to our members or something that would be helpful that might depict for what services telehealth would be on board equally as effective, although it may not be as preferred compared to those things that would require an in-office visit? Or is there anything that you think support we could lend?
I've tried for some things, when we've had like a provider that needs to be out and providing services via telehealth, where I call the patient myself and say, hey, this is your depression follow-up. I've already talked with Dr. So-and-so and he's fine doing it via telehealth. So I think there's some of that. It reminds me a little bit of like the office visit, ER, urgent care kind of lineup. Like, here's what you go to urgent care for, and here's what you go to the ER for. So kind of here's what might be good for telehealth, and here's what you really should try to go in for. I think you get some movement that way with some patients. But does anybody else have any thoughts?
I guess it's a little striking because there are regions where substance use disorder treatment is one arena where we found some providers saying that engagement was higher than ever, that through telehealth had all sorts of folks accessing care that had not accessed in the past because of stigma and that associated with treatment. And then the other is just I think we know for so many of our Medicaid members, just transportation issues are complicated, the transportation itself, or because they also have children or whatever the case might be. So there were some providers early on that certainly aren't recommending that be the only way we provide treatment. I'm not trying for that at all, but just saying that it did seem like a nice adjunct. And when we look at the younger generations, particularly, many of them prefer some kind of online kind of access versus in-person visits. And even like for me, I would way rather do a telehealth visit than have to take the time to go in to see a provider unless there's some reason you need to sort of be physically checked out. So, my point in that is sort of being an older generation that I still think that so much of our lives are now moving towards more of a platform where this would be more familiar. So if you see things that you think we could do, education, outreach, anything, training, something, please let us know, because I think this is an area where we could definitely have reach and try to get behind your efforts if it would be useful. But it sounds like you did a lot of work and it really had a hard time moving the dial. So it might just be time.
Vicki, is that all across all provider types?
In terms of access?
Yeah.
We noticed it, SUD seemed to comment the most about it. And then places where there was a lot of different access issues in terms of getting out to rural areas where there seemed to be a lot more use of telehealth. But then, once the broadband kicks in and that's a problem, then it's very difficult. So I know that we tried to look at some mobile, the state tried to look at some mobile units and that kind of thing to help with broadband, but I think that continues to be a challenge.
Yeah, I can't speak for everybody, but I know that at least for grant integrated services, one of the difficulties we run into as being a county department, and I don't know how many county departments there are anymore for BHAs across the state, but we are subject to public records requests, which make it really difficult to have security through email. And with telemedicine, that, you know, Zoom, WebEx, it incorporates email addresses, different things that you have to sign in to, you know. And so I would, again, for us, we had a lot of in-person visits still throughout 2020. Our crisis department never went to any telemedicine. I would be interested, at least for, and again, it's kind of difficult to speak for the whole group because we all do different things in different platforms and different entities, different, you know, but I would guess that our uptick or increase was phone contact. So, you know, I don't know, for what that's worth. For us as a county agency, though, the email, PHI and email is a difficult thing to navigate for us.
Thanks, Mike.
Yep.
Okanagan, do you have the same issue as Grant County? Because I believe you guys are a county entity also, right?
No, we're actually we're a nonprofit. But I think some of the things just listening that we experienced, we had a lot more phone contacts, especially in the beginning, because we have so many people that live in outlying areas that don't have internet. So, and we still continue to see a lot of people that will do their sessions via phone. You know, I don't know if that's a mix between that's their preference or what exactly, but I know we did a lot more phone contacts, especially in the beginning on the SUD side of things. And I think some of the comments that we heard from people is because everybody was home, right? So they didn't necessarily have the privacy in their home to do a Zoom contact. So they preferred the phone so that they could, you know, go outside or go to a more private area, or just it be more of a one-sided conversation instead of the family overhearing their whole counseling session. So I think it was just a mixture of a bunch of different things.
Yeah,
I would agree with that, Lisa. I would totally agree with that.
Anyone else?
Wendy, I had a quick question. Is Loretta on the call? I'm not seeing her. Maybe she's just not on my screen.
I don't think
I'm
she's
not
on the
seeing
call.
her either.
Okay, I'll follow up with her in a minute. I was just curious for SUD. I don't know if there's any other SUD specific providers that can comment on what they observed in terms of ticking up or ticking down related to some of these telehealth options.
I think the center has said at a lot of our meetings that they are continuing to have good support with that, and that's what they're primarily doing. So,
okay, thanks, Jackie. You and I will talk more too.
and I'll just say for case management with like Melina, so we have the ability to do like a Zoom visit, and initially everyone was, you know, like we got on board, and a few members that were willing to do it. But then after a while, it just kind of fizzled out. Like, you know, I don't need to see you. I can hear your voice and be okay. I think initially we didn't have as many members that wanted to do it as we thought we would, but the ones that were excited to do it fizzled out quickly.
You know, the other thing that is kind of interesting, and I'd have to do some asking, but I don't know whether they got, you know, the telehealth modifier attached to the service, but with our WISE kiddos, as long as you had a closed end on both sides, we actually had some staff members actually do like a gaming platform where they could actually play a game and visit. But I don't know whether they actually got the telehealth modifier attached to it, so whether if it was just but yeah, we tried to, like Lisa had said, we scrambled at the beginning to try to get platforms and Zooms and WebEx all set up and things. And I'm not sure if it really just got off the ground for us. Not that it didn't happen. We had some, but
I think for us to continue to keep an eye on, just because I think as we move forward, there'll be some percent of the population that will want to continue care through telehealth mechanisms. So looking at how it is we remove barriers for those that will do or only be willing to will be important across the state, as we all know. So if there's ideas or thoughts of other ways we can come together, it'd be helpful to know. Also, a number of us, and I imagine others in the call, are involved with the University of Washington Behavioral Health Institute, and they have a committee that's looking at access to care, including telehealth. And there's also a broadband subcommittee that is working within itself and with other experts, including the Department of Commerce. So I guess, maybe I think is kind of in thinking about this rather than thinking, well, sort of, the COVID pandemic came and then, shapes to be whatever it is over time. We probably need to figure out how it is we get from A to B in a more purposeful way where we're not under crisis, based on what individuals are wanting and needing to help support their recovery efforts, whether it's physical health or behavioral or both.
Stephanie, did you want to say something? I saw you unmute just a minute ago. Okay. To your point, Vicki, we will be having a telehealth discussion at our board meeting today. We had put an RFP out to do a community assessment to understand the feasibility and desirability for telehealth, potentially kiosks or telecarts around the regions that could be strategically located. So we'll have that conversation regarding the finalists for that proposal today at today's board meeting. So through that assessment, if the board approves the proposal, then we can have that assessment and have some data by the end of the summer to understand how people want to access their telehealth, whether it's through a kiosk or telecart in a strategically located area, or if it's in different ways within their homes and their capabilities and that. So more to come on that front. Anything else?
So Wendy, I have a question of Vicki. Do we have time? So Vicki,
Sure.
I know that King County is part of the pilot project with that BHI, the Behavioral Health Institute, and they were going to add a rural partner somewhere. Do you know if that has happened and where that rural partner is? She's frozen. It's okay.
And just for everyone else, what Relinda's referring to, they're looking at another tool to assess the level of integration, similar to what the MEHAF did, so that it can be standardized across the state. And many of you may remember doing the MEHAF with MRI or in the past couple of years. And so the state is looking at another way that a tool that can be used by clinical partners as well as the MCOs, so that it can all be standardized and we can get a report on how integration is moving across our states. So more to come on that. They're just piloting it right now, so nothing's rolling out. It is in the pilot project, and they were looking for a rural partner to pilot, and Vicki is on that team. But I was hoping if I could talk long enough, she would jump back on, but that just is not happening. So more to come. More to come on that. Anything else? Anyone else? About anything that's been discussed in today's? All right. Well, if no one has anything else, I will give you, I'm not very good with math, 30 minus 5 would be 25 minutes back in your day. I appreciate you joining us, and we'll see you April 5th as our next WPCC meeting. Just a reminder that monthly reports are due Wednesday. Our next population health plan, if you're participating, is next Tuesday. And we'll hear from Columbia Basin Health Associates, and I believe it's Merit Group in April. So thanks everyone for joining. Have a great day. Bye-bye.